So we are here at the Heart Failure Congress of the Heart Failure Association of the ESC, Vienna 2018. And I'm happy to report on our new consensus document, how to diagnose heart failure with preserved ejection fraction. And you know, heart failure with preserved ejection fraction is a clinically most relevant problem. There are millions of patients around in Europe. We see them all the time. And we do not really know how to manage these patients. However, these patients suffer from repeat heart failure hospitalizations and also adverse events, cardiovascular death. We don't have good specific therapies for these patients. And one underlying problem is that it was not so easy to identify these patients and diagnose true heart failure underlying the signs and symptoms in these patients. And according to Braunwald's definition of heart failure is characterized by functional alterations of the heart, where during rest or at least with exercise, cardiac output is reduced, stroke volume may be reduced, and filling pressures are increased. This is not so easy to measure, but we are getting better and better. Now, Walter Paulus and his team came up more than 10 years ago with the first consensus on how to diagnose heart failure, and we used it over the last decade. But a lot of innovation came up with respect to novel parameters that characterize cardiac structure and function, new technologies, and a better understanding of the pathophysiology. Now, our new consensus document is a four-step approach. The general first step is the pretest that can be done by a GP. Is this patient likely to have heart failure underlying his signs and symptoms, or are it more the comorbidities? The second step is the E step, echocardiography. That should be done by an experienced cardiologist, and here we come up with a score system where HFpEF is excluded or highly likely or in the gray zone, and this is often the case. And if it is in the gray zone, we proceed to the next step, which is exercise testing with either echocardiography to see functional changes occurring with exercise when the patient gets dyspneic, or invasive hemodynamics at rest and with exercise. And with that, then we can definitely diagnose heart failure with preserved ejection fraction or exclude it. And the last step is a thorough workup for underlying etiology for targeted therapies of these patients. Thank you very much.